This is a carbapenem-resistant Acinetobacter baumannii complex (CRAB) isolate that is best treated with a dose-optimized sulbactam-based backbone plus at least one additional in vitro active agent with cefiderocol, MIC 0.25 micrograms per milliliter, fully susceptible, being the single most attractive companion agent here, given that sulbactam, durlobactam, tested only intermediate, 8/4 micrograms per milliliter. No available regimen has been shown to consistently reduce mortality in CRAB, so treatment must be individualized to the infection site, host factors, and PK/PD. The two decisive results in this report are the cefiderocol MIC of 0.25, well within the susceptible range, and the sulbactam, durlobactam MIC of 8/4, which sits one dilution above the susceptibility breakpoint of less than or equal to 4 micrograms per milliliter. Interpreting the susceptibility panel, the beta-lactam susceptible/intermediate results, ceftazidime S, cefepime I, cefotaxime/ceftriaxone, are clinically unreliable and should be disregarded. Third-generation cephalosporins and ceftazidime have no meaningful role against CRAB, regardless of the automated MIC. A baumannii is intrinsically and adaptively resistant, and these readings do not reflect achievable in vivo efficacy. Carbapenem resistance is confirmed, meropenem MIC8, consistent with the OXA-type carbapenemases that dominate CRAB epidemiology, most commonly BLA OXA23. Ampicillin, sulbactam MIC 16/8, intermediate, signals reduced but not abolished sulbactam activity. Sulbactam remains the key active component and can often be overcome pharmacodynamically with high-dose, extended/continuous infusion. See below. Fluoroquinolones, Cipro, Levo, resistant. TMPSMX resistant, no role. Aminoglycosides report susceptible, amikacin less than or equal to 16, gentamicin 4, tobramycin less than or equal to 2. These may serve as adjuncts, but as monotherapy against invasive CRAB, they are inadequate and site-dependent, poor lung penetration. Minocycline intermediate, 8. Tigecycline not reported. Tetracycline class agents are salvage/adjunct options only, with weak evidence. Minocycline susceptibility across contemporary U.S. CRAB collections is 50%. Cefiderocol susceptible, MIC 0.25, a very low MIC, near the bottom of the distribution. Surveillance MIC 50/90, typically 0.5/2. Sulbactam, durlobactam intermediate, 8/4. Notable because Soldur is susceptible in approximately 97% of CRAB isolates, MIC 90 usually 4. An intermediate result places this isolate in the small minority. Genomic analyses tie SUL-DUR non-susceptibility to metallo-beta-lactamases, for example NDM, or non-enzymatic mechanisms. This raises the possibility of an MBL, which would also matter for cefiderocol stewardship. The core treatment debate. The central tension is between the two newest, most active agents, and the panel gives a somewhat unusual answer. Cefiderocol very active, Soldur only intermediate, inverting the typical hierarchy. Case for a sulbactam-durlobactam-based regimen, the guideline-preferred default. Soldur plus imipenem. Cilastatin is the IDSA 2024 and ECIL-10 preferred regimen for CRAB, driven by the ATTACK trial, where Soldur was non-inferior to colistin for 28-day mortality with better clinical/microbiologic cure and markedly less nephrotoxicity. However, this isolate's MIC of 8/4 is above the less than or equal to 4 susceptible breakpoint. Using Soldur here would be off-label with respect to susceptibility. If chosen, it should only be as part of combination therapy with dose optimization, and durlobactam does not inhibit MBLs, so if an NDM is driving the intermediate result, Soldur efficacy would be compromised. Case for a cefiderocol-based regimen, arguably the better fit for this isolate. With a cefiderocol MIC of 0.25, this drug is fully and potently active. Cefiderocol is FDA approved for HABP/VABP and CUTI and is stable against serine and metallo-beta-lactamases. The caveat is trial data. In CREDIBLE-CR, cefiderocol monotherapy was associated with numerically higher mortality in CRAB, so guidelines caution against monotherapy, whereas cefiderocol-based combinations have shown improved outcomes in meta-analyses/observational data. For example, the PISA cohort showed lower 30-day mortality versus colistin-based regimens, particularly in bacteremia. On-treatment emergence of cefiderocol resistance is a documented risk. Approximately 50% of microbiologic failures in one cohort, reinforcing combination use and follow-up MIC monitoring. Sulbactam dose optimization is non-negotiable, regardless of partner. Sulbactam, as ampicillin, sulbactam, or the SUL component, is the backbone. High doses, greater than or equal to 9 grams per day of sulbactam, extended/continuous infusion, can overcome intermediate MICs and improve microbiologic outcomes. Colistin remains the fallback partner where newer agents are unavailable, high-dose sulbactam plus colistin, but it carries dose-related nephrotoxicity and poor tissue penetration, and underperformed SUL-DUR in ATTACK. Suggested approach for this isolate: confirm and characterize. Repeat/confirm the SUL-DUR MIC, intermediate at 8/4 is atypical, and pursue carbapenemase/MBL genotyping, OXA23 versus NDM. An MBL would explain SUL-DUR non-susceptibility and would elevate cefiderocol's importance while mandating close monitoring. Backbone: high-dose, prolonged infusion sulbactam, greater than or equal to 9 grams sulbactam per day as the cornerstone. Primary partner: given the cefiderocol MIC of 0.25, cefiderocol is the most rational second active agent for a serious/pulmonary or bloodstream infection, used in combination, not as monotherapy, with source control and follow-up MICs to detect emergent resistance. Alternative/adjunct: if MBL is excluded and SUL-DUR is preferred per institutional guidance, SUL-DUR plus imipenem is the guideline default, but should be recognized as intermediate here. Consider it combination only. An active aminoglycoside, tobramycin/amikacin, or a tetracycline, minocycline/tigecycline, may serve as adjuncts depending on site. Tigecycline/minocycline should be avoided as primary therapy for bacteremia, pneumonia, or UTI, and reserved for intra-abdominal/skin soft tissue infection. Tailor to site. Bloodstream/pneumonia favor cefiderocol or SUL-DUR-based combinations. Avoid tetracyclines for these sites. For CUTI, cefiderocol alone is well supported. The overall picture is a highly drug-resistant CRAB, where the two best options are a potently active cefiderocol and an intermediate SUL-DUR. A dose-optimized sulbactam backbone plus cefiderocol, guided by molecular testing and repeat MICs, is the most defensible regimen for a serious infection.